Our second speaker is Dr. Rudolf is the Canada Research Chair in Early Intervention and a professor in psychiatry at Dalhousie University. Dr. studied medicine and neurosciences at Charles University in Prague. He was trained in psychiatry at the Maudsley Hospital in London. In 2013, he launched the FORBOW program. That's F-O-R-B-O-W. There's a website that you can look at, www.forbow.org, and we can give it to you later if you wish, with the aim to prevent mental illness in youth. He is also the editor of the journal Depression and Anxiety, and he consults for the World Health Organization on the classification of mental disorder and works on the 11th revision of the International Classification of Diseases. He is an author of over 180 articles on mental illness, its causes and treatment. He is a recipient of the Max Hamilton Memorial Prize 2014, and I'm going to say this wrong, I know it, and the Royal Macganison Prize for Mental Health Research in 2016. Dr. treats people for depression and bipolar disorder at the Mood Disorders Program at the QE2 Hospital in Halifax, Nova Scotia. Please welcome Dr. Rudy
Hello, everyone. It's incredible how many people are here on a Saturday morning. I can't believe that. To listen to psychiatrists on top of that, right? Okay. Yeah, no, great to be here. Great to be on a golf course, and will be even more interesting tomorrow. And yeah.
Just for the live stream, sorry.
Yeah.
Don't move around too much.
I won't move around. Yeah, I promise.
And repeat the questions.
And I'll repeat the questions.
Awesome. Thank you.
Yeah. Okay. They are well organized here. So the brief story is I'm a psychiatrist and I see clinically adult patients mostly with severe mental illness, mostly mood disorders. And I do most of my research with children and adolescents, and I'll tell you the story why. And I hope that there may be something you find that is useful for what you're doing. I'm aware most people are in surgery or medicine here. And, but it's also, I'd like to let you know about something that's happening in Halifax and in Nova Scotia right now. And the question, the title is, can we prevent mental illness? And we usually are asked to show where our money is coming from, so all that I will be talking about is funded by grants from federal sources, international sources, and from Nova Scotia as well. And I have accepted no money from pharma companies or anyone with commercial interest, so if you want to know. And what I'll be talking about is severe mental illness. It's a bigger category. It's not in the classification as such, and mostly it is the three diagnostic categories below combined. So schizophrenia, or psychosis if you want to, bipolar disorder, that's what used to be manic depressive illness, and depression, and especially the major depression, the definite clinical depression that requires often specialist psychiatric care. And I like to start with questions. So think of these three. You probably don't work with these in your everyday practice, but you probably have come across people. And so just have a guess of 100 Canadians, how many are likely to develop schizophrenia, bipolar disorder, or major depression at some point in their life? 45? 25. So 1 in 4, okay? 32. 66? Like the majority of Canadians have severe mental illness? 3. Okay, so we have 3, we have 66. That's a good start. It's a broad range. Okay, more guesses? 20. 20. 20, yeah, 20 is a good one. Yeah, so if we were south of the border, the 20 to 25, that would be the number. In Canada, we are more conservative. So based on Canadian data specifically, it's 11, so a little bit more than 1 in 10, and I'd say this is perhaps the most conservative estimate. So I would say at least 1 in 10. And when you sum it up, then schizophrenia is perhaps the least common. Some argue the most severe, about 1 in 100. Bipolar disorder is a little bit more common, about 2 in 100. And depression, even just taking the severe cases, remains the most common and burdensome disease in our population. I have a second question, again relating to these 3 diseases, schizophrenia, bipolar disorder, and depression. Of 100 people who are going to develop one of these 3 at some point in their life, how many will already have a mental disorder by age 18 years?
80%.
80%. So is that the same person who guessed 66? No, okay, just checking. Yeah, okay, 80% is our first number. 5%. So we have a pretty good spread. Yeah, you use the 100 scale. That's 30. Yeah, 1 in 3. Yeah.
I mean, the 80 I was saying was a healthy level going to develop, right?
Yeah.
Not just.
Yeah. Yeah. Okay.
Yeah.
And again, the answer depends a little bit on where you take it from. And I think the 1 in 3 would have been really the answer most people would guess until, based on the textbooks. When we look up the best data that's available, and that's actually taking a large population sample from birth and following them up until at least middle adulthood without losing too many of them, as they managed to do in New Zealand. The answer is actually very close to the 80. Well done. And this has been shocking because really, it's even 15 years ago when I was finishing medical school, the chapters about mental illness were saying, we're really starting by the sentence, the typical onset of schizophrenia is in the early 20s of depression or bipolar. There wasn't anything written of what happens before that, right? And all that we learned in the past 2 decades really is teaching us how much has happened up to that point. We also know now that the early 20s is not really true because people don't usually come to see us with the first episode. There's typically a delay between sometimes not help seeking, sometimes misdiagnosis, sometimes family trying to hide if they can, or cope as long as they can. And so mental illness starts early. And often it's not the same diagnosis in childhood as the eventual diagnosis in adulthood, but the vast majority of people who will have severe mental illness, they already show signs and symptoms as children and adolescents. Also, when we look at below the age of 15, it's still over 50%. So we know half of mental illness before age of 15 and 3/4 of it by age 19. And this is really, why many of us who start with adult psychiatrists are turning to the history and, can we do something earlier? These are the details of the study from Dunedin. So these are bar charts lying on its side, if you want, and the length of the bars is the frequency of the childhood problems, and the full bars are the frequency in those who will end up with adult diagnosis. The empty bars are those who will not end up with adult diagnosis. And you can see that almost all the filled bars are longer than the empty bars. And you can see also that the childhood precursors are kind of promiscuous. When we look at anxiety, it precedes not just adult anxiety, it also precedes depression and bipolar disorder. What we call oppositional defiant disorder, so these are these extremely difficult children. These are these, who thrill still throwing multiple temper tantrums per week, even or per day, even when they are 8 years old. This is a common precursor of all kinds of mental illness in adulthood. Not necessarily, like by far not every child with oppositional defiant disorder develops mental illness, but it's a strong predictor. It's like at least doubles the risk. And turning back to severe mental illness, so mainly depression, that's the bulk of the cases. Canadian data show that these illnesses cost Canadian society more than all types of cancer combined. So this has been a little bit shocking when it came out, when people ask, what's the biggest problem in our health? Many people say cancer. So when you sum just depression, bipolar disorder, and schizophrenia, it costs us more than cancer. A huge toll on individuals, families, society. In Canadian terms, approximately $50 billion a year. That's the cost of severe mental illness, not all mental illness. Why? Well, one of the reasons is that it starts early. Mental illness is the chronic illness of the youth, right? It kills some, not most of people, but people suffer it for many decades. So, think of the typical age of onset of cancer, think of the typical age of onset of schizophrenia. They are very, very different. And we see this, life course of the common disorders of health. So anxiety, very common, starts in childhood. Mood disorders, depression, bipolar disorder, typically starts in the second decade of life, in the adolescence or up to young adulthood. Psychosis, schizophrenia, and other types of psychosis soon after that. Diabetes and other metabolic health conditions are really the big bulk of problems in the midlife. They increase cardiovascular morbidity and mortality later on. And then going into the senior years, dementia is the biggest problem, right? And now I'll tell you how that all these problems are actually closely related. Anxiety strongly predicts mood disorders. Mood disorder, most cases of psychosis are typically preceded by mood problems. Well, mood also strongly predicts diabetes. All these relationships are, not like 10% more. All of these relationships at least double the risks. Mood disorders also predict dementia. There has been a large review of preventable cases of dementia, and the top preventable causes are mood disorders. Psychosis predicts diabetes as well, and psychosis predicts dementia. So you have all this relationship, the life course continuity of ill health, that together concentrates the poor and costly health outcomes in a minority of our population. So typically the numbers sum up to 20% of the population are responsible for 80% of the health and social costs. And mental illness is the beginning of this, because mental health problems are the first manifestation of this chain of ill health over the life. So here are the references to all the relationships numbered above that. So back to severe mental illness, we can see it starts early and it's super costly. And it's probably on the causal chain to later health problems. So what can we do about it? Well, we spent decades, centuries arguably, trying to cure it. And we've been tremendously unsuccessful. With the 20th century neuropharmacological revolution, we have drugs that can modify the course. We can avoid the excesses of the uncontrolled psychosis and of the deepest depressions and strongest manias. But we are not really returning most of people with severe mental illness to fully productive life when they can fulfill their potentials. People with severe mental illness still dying 15 to 20 years earlier than people in the general population. Largely to the smaller proportion of that is due to suicides, larger proportion of that is due to the increased medical morbidity that's associated with mental illness. So what about preventing it? Wouldn't that be better? And many of us are thinking, yes, it might be better. A universal prevention, something we can do for everyone in school is one way of doing it. But the larger efforts for universal prevention are finding that the kids who are at the highest risk, because they are from the highest risk families, are actually benefiting the least. So we probably need, at least as a complement, what we call indicated or targeted prevention, and that has two stages. First, identify who needs help the most, and then intervene. So I'll take you through how we're trying to address these. I will refer a lot to the FORBO study. So FORBO is an abbreviation. It stands for Families Overcoming Risks and Building Opportunities for Well-Being. And yes, there is the website that you can look up, www.forbo.org. And I first tell you how we identify who needs help soon. And there's a history to it. We are not the first ones to try early intervention to prevent severe mental illness. But most of the previous efforts have relied on what's called at-risk mental state, or medically you will know it as the prodrome. And this is like something that looks almost like severe mental illness, but just misses the diagnostic criteria, not quite reaches them. And there's been a lot of knowledge accumulated on this group of typical treatment-seeking adults who just do not get the diagnosis, but are at high risk of getting it soon. And yes, we can make a difference, but no, we cannot return them to full functioning. So this at-risk state may be too late to intervene if we think of full functional return to fulfilling potential, completing education, starting families, having fulfilling jobs. So we decided we need to go earlier than this. We know that the signs start much earlier. So this at-risk state, they typically work with people around 18, 20-year-olds who already come to seek treatment. We think we can go earlier, and we think if we go earlier, it will not be directed to one illness. It will be cross-diagnostic. And that's why I started off speaking about severe mental illness rather than just depression or just schizophrenia. Because the early signs are, as I showed you, promiscuous. They are strong predictors, but they are not specific to one adult outcome. So our risk identification strategy is a combination of genetic risk, mostly family history, and what we call antecedents, earlier, smaller problems that precede and predict mental illness later on. I speak first about the genetic risk. We started off by summing all the data looking at the risk of mental illness in sons and daughters with mental illness compared to controls. And again, looking at the big three, schizophrenia, bipolar disorder, and depression, we found that 1 in 3 sons and daughters of parents with these conditions will develop one of these 3 conditions by early adulthood. It actually plus depression. So that's a lot. That's too much to just watch. It's at least 2. If not just about 4 or 5 times increased risk of schizophrenia, they also have doubled risk of depression and doubled risk of bipolar disorder. So that's why the summed risk is 1 in 3. We used to tell people it's 1 in 10. That's the specific risk of also having schizophrenia. But what people care most about, will my son will have severe mental illness, not just will it actually be exactly this one. The molecular genetics, I will not ask you to take in the details of this slide, but we now are able to measure the whole genomes, over 1 million variants across the genome, test them all. When we sum them up, they can predict mental illness pretty strongly, and they're showing the same as the family history data. Most of the predictors are not specific to bipolar disorder or depression or schizophrenia. Most of the predictors will predict increased risk of the 3 of them. Perhaps to a different degree, but that's what we see. There's more gene risk variance for mental illness than for bipolar disorder, for example. Now I'll tell you about the other part of our risk identification strategy, the antecedents, or precursors if you want. These are conditions of the individual that we can see early and that precede and predict mental illness. We have looked through the literature, what are the best ones. We found 4 that we focus on first. Affective lability, like changeable moods, something that Andrew referred to as affective instability, anxiety, psychotic symptoms, and basic symptoms. Take you briefly through these with quotes from our participants. So affective lability, here is a parent description. He often gets grumpy and unhappy quickly and for no apparent reason. We never know what he will be like the next hour. You know, this is affective lability. The mood changes, it is out of proportion to what's happening. Now, you remember me mentioning oppositional defiant disorder, the difficult kids. You know, that's one early manifestation of affective lability, and it predicts lots of problems later on. And later on, it's often, say, he's cranky, you know, irritability, that's part of it. And a new diagnosis called disruptive mood dysregulation with dysphoria. That's something that people try to replace the misdiagnosed childhood bipolar disorder with. That's, you know, another manifestation of affective lability. So that's our first antecedent. We have affective lability scales that we use to measure it. Anxiety, a very, very common experience, very strong predictor of problems later on, especially depression and bipolar disorder. Here's a description from an adult participant who says, in my teenage years, I was paralyzed with anxiety. If I got help with it, perhaps I would not have bipolar disorder now. Well, I don't know, but it's a hypothesis worth testing. That's what we're trying. Anxiety is very common, and it typically starts in childhood. And it's very treatable. That's the good thing about it. Much easier to cure anxiety than schizophrenia. We know how to do it. Psychotic symptoms. You may be surprised that I'm mentioning this when I'm talking about kids, but things like hallucinations, hearing things other people don't hear, are actually more common in childhood than in adolescence, and more common in adolescence than in adults. Many children have unusual experiences. If you don't ask them about them, they will not tell you. Very soon they learn, you know, this is not something to share, because they get strange looks when they say something. And here is a quote from an 11-year-old girl participating in Forbo. I kept hearing an evil laugh. I also heard a loud voice at my grandmother's house saying, "Go home." I asked my grandmother, "Did you hear that?" She responded, "Hear what?" Right? So at that moment, she believed this is a real voice. Grandmother didn't hear anything. So this is an example of psychotic-like experience or psychotic symptoms. This girl is not psychotic. This is an isolated experience. She's not impaired at this stage, but it's an early sign of vulnerability to unusual perceptual experiences that later may develop into psychosis, perhaps especially if we learn to keep them in and not to test them. The last one I will mention are basic symptoms, also unusual experiences, but these come with immediate insight. The person immediately knows something's wrong with them. They find them irritating, disturbing. They either include perceptual disturbances, you know, just like hallucinations, although I know it's not, and or loss of function. So here is an example. Suddenly I could not understand what words meant, words that I had known before. It happened several times in the past few months, but not before. I wondered what was wrong with me. So that's a typical basic symptom presentation. That's not something we typically learn in psychiatry about here in the Anglophone countries. It comes from German psychopathology, but they found in long-term studies that it strongly predicts psychotic illness later on, with a delay of many years. So not like the at-risk mental state that predicts conversion in the next year. This predicts like 6 years later on average. So that gives us enough time to intervene. That's why we chose it. I tell you now something about the Forbo cohort, the kids that are coming into the Forbo. I actually forgot to update this slide. We now have over 300 of them, about 310 children and adolescents from Nova Scotia are now participating. When they're joining the cohort, they are on average 10 years old. So the average participant is a child when they are starting. And then we see them once every year. So we have actually completed more than 700 assessments with them by now. The parents are also participants. So we interview the parents and the kids, and then we do cognitive testing of thinking styles, we do brain scanning, we take saliva for genetic testing. So these kids do a lot with us. They usually spend about half a day, and they leave very happy, and they want to come soon because they get all that attention. And about half of them come in because they are their parents are patients with severe mental illness. The other half are random cross-section of Nova Scotia population, which is important to mix the two groups. Having the offspring of parents with mental illness concentrates the risk, but mixing with the general population is important because being in the study does not mean that you have mental illness in your family, right? And we can also use that to extrapolate to say something about mental illness vulnerability in the whole population. We follow an innovative design. It's called trial within cohort. So trial meaning clinical trial, and cohort is a group of people that you follow over time for a long time. And this is actually a new and probably more externally valid way of testing interventions, especially interventions that are compared to nothing. And for a preventive intervention, nothing is the right comparison because nothing is exactly what happens in practice at that stage. And so we have randomized trials embedded within the FORBO cohort. Everyone gets follow-ups, but some people are offered interventions, and they are randomly selected from the cohort. So just a few words about the first 300 offspring. Actually, more than half of them are sons and daughters of people with depression, bipolar disorder, smaller group sons and daughters of people with schizophrenia. Those are harder to find. We're working on finding more of them. They already have many diagnoses when they come in. So actually there were already 2 cases of bipolar disorder, 28 cases of major depression disorder when they entering the study. Some of them are older, right? It's a broad age range, so the late teenagers, some of them are already ill. When I sum it up, about 1 in 4 has an internalizing disorder, that's anxiety or depression, and about 1 in 4 has an externalizing disorder. Its most common externalizing disorders are ADHD, attention deficit, hyperactivity disorder, and the oppositional defiant disorder that I mentioned. And now I look at the antecedents, and are they linked to the family history, to whether a parent has mental illness? The answer is yes, they are. Affective lability increased. In the blue are the offspring of parents with depression. Red are the offspring of parents with bipolar disorder. In the yellow bar is the rate of affective lability among offspring of parents with schizophrenia, and all of them are higher than affective lability in offspring of control parents with no diagnosis, which are in green. Similar for anxiety, except anxiety is not increased in offspring of parents with schizophrenia, but it's highly increased in offspring of parents with both depression and bipolar disorder. Psychotic symptoms increased in all high-risk groups. Basic symptoms increased, especially in bipolar and schizophrenia offspring. And overall, higher rates of antecedents in the 3 high-risk groups compared to controls. So that's just confirming expectations, if you want. But how do these work? The reason we pick these antecedents is we think they will predict who will end up developing severe mental illness. And we are now in the 4th year of the study, and actually this is the first time that we can tell at least a little bit whether it works. Because we completed 400 follow-ups of over 200 individuals who entered FORBO. They did not have severe mental illness. They did not have major mood disorder or psychotic disorder at baseline. But they developed, about 22 of them developed it on follow-up. That is an incidence of 55 per 1,000 person years. That's actually worse than I feared. It's more, but it allows us to have some answers earlier. The mean age at onset, 16.9 years. So 17-year-old is on average when they develop the first episode of major mood or psychotic disorder. The onsets are strongly linked to the family history. not just whether they have a parent with severe mental illness, but how many parents affected. Because you can see that the third bar on the right, that's the rate of onsets in children where both parents have a major mood or psychotic disorder. And you can see that it's higher than in the middle bar, which is one parent, and it's definitely higher than in the offspring of healthy parents. So you see this gradient of risk depending on how many parents are affected. These are biological parents. Now, what about the antecedents? Well, we actually had about half and half kids who had at least one antecedent and who had none. So about 200 follow-ups of people with at least one antecedent, 21 onsets among them. About 200 follow-ups of people with no antecedent, one onset among them. So the risk ratio, the ratio of risk between these two groups is 20-fold. So, we picked these based on literature, but they're working, they're predicting who will develop mental illness. They actually work almost perfectly, especially when we combine it with the family history. And moreover, this is the gradient of risk depending on the number of antecedents. Because we have kids who fulfilled 2 of the 4, or 3 of the 4, or all 4 of them. You can see when we get to all 4 of them, the rate of developing severe mental illness among them is 20% per year. It's massive. So we think when we pull these together, the family history, we have gradient of how many parents affected. We're looking at more remote relatives as well now. And when we look at the number of these antecedents, we can see a gradation of risk, and perhaps we should develop a gradation of early interventions that corresponds to it. Because those who have high family loading and multiple antecedents, they probably need intervention for definite. Well, I showed you that there's the gradation of risk with family history, but yet, across the population, most cases of mental illness do not have affected parents. So it works as a risk enrichment strategy, but it would not work on catching everyone who's going to develop severe mental illness. Well, part of the reason is we often don't know the full family history, because there's many children growing up where at least one of their parents disappeared from their life early on. We don't really have the family history. There are children who are adopted. We know that on average they are at high risk. And part of the reason is that we're getting smaller and smaller families, so the genetic risk does not necessarily manifest in actual cases in the near family. So we're looking at whether we can actually start using a genetic test, not to replace family history, but to complement family history, especially those where we do not know the health of enough relatives to say, and we'll be testing whether this actually helps the prediction. It may be controversial, should we use genetic tests to decide who gets a potentially helpful intervention, but it may be effective. So it's one of the directions that we will be pursuing. And we're doing that in a consortium. We agreed with people in the US, in Denmark, other people in Canada. In Quebec, there's a beautiful collection of multi-generational families, multiply affected by mental illness, also in Switzerland and in Netherlands. I say a little bit about the environment, because of course it's not all genes that causes mental illness. These are my, top things that I think of. Birth complications. We know that being small for weight, protracted delivery, hypoxia delivery predicts risk of mental illness. Probably the biggest single predictor is poverty, low socioeconomic status, poor uneducated parents. Care environment. Growing with both parents who are caring for you is protective. Childhood maltreatment, so this is abuse and neglect, a huge predictor of all types of severe mental illness. Bullying, growing importance. The peer group has probably become even more important, has always been important for especially teens, but has become even more important, and a strong relationship with depression and other types of problems. And then, of course, toxins and drugs. Cannabis being a big issue in Canada now, because the access of youth to cannabis may increase with the legalization process. And we know that cannabis is probably responsible for about 14% of psychosis in adulthood. It is a causal factor. It also reduces our IQs. So it's proven to be harmful, and it will become more accessible. So it will not become a smaller problem. So we looked at the socioeconomic indicators in our in Forbo, and we probably this is close to a cross section of the population. About 60% of the kids are growing in a complete family with both biological parents present. About 70% of the mothers have at least high school education. About 60% of the affected families and 70% of the control families have income more than $40,000 per year. And there's not really huge differences between the affected families and the unaffected families in Forbo. That's part of this is because we look for comparable families from the same region, same schools, when we look at the controls. The one when there is actually a significant difference is in wealth, whether they own their home. That seems to, that's where the years spent with mental illness kick in. You may not have accumulated the wealth to buy your own home. But overall, not big differences and pretty widespread. We really have managed to reach some of the more deprived families within across Nova Scotia. Then next, I'll look at adversity, mainly childhood maltreatment, so physical, sexual, and emotional abuse. You can see affects a substantial minority of children, but there's actually no difference in the rate of abuse based on whether a parent has severe mental illness. I think this is good to see for people, because people often worried about children who growing up with parents with mental illness. And it's not, parents with mental illness tend to be good parents in the majority. They are sometimes unavailable because they are ill, but they don't seem to abuse their children any more often than others. I mean, the most common perpetrators of abuse are parents. And you can see, for example, for physical abuse, we're actually getting higher rates in the control families. Where we see difference is exposure to violence. This is not violence towards the children. These are typically arguments within the family. So those are a little bit more common in families when there's mental illness. Bullying affects between around 12-13% of youth. And of course, we are interested how much these adversities relate to who develops mental illness, which I'll show you next. But just to say, looking at childhood maltreatment, we do not see a huge effect of mental illness in parents. We do see a huge effect of poverty. We have a sixth grades of socioeconomic status. Each one step on the scale of 6, makes bigger difference than having a parent with severe mental illness. So the rate of childhood maltreatment goes from 3 to 5% among the well-off families to 50% among the poor families. This is hard to see in one of the richest countries in the world. And adversity predicts mental illness, and all types of mental illness essentially are at least doubled by maltreatment. It doubles the risk of externalizing symptoms, doubles the risk of more than triples the risk of anxiety, increases the risk of severe mental illness. Interestingly, bullying seems to be at least as important and stronger, has even stronger effect than child abuse and neglect when it comes to depression and anxiety. So a huge factor. We ask both about the traditional bullying in school, physical bad words, but also about cyberbullying, which is becoming more widespread problem with the importance of social media in interactions between youth. So I conclude here. We have confirmed and demonstrated we can predict severe mental illness onsets. They happened often, they happened early, and they are predicted by antecedents like affective lability, anxiety, psychotic symptoms, and basic symptoms, and of course they are predicted by family history. This is not necessarily new. The genetic tests may probably improve the prediction further, and so can environmental adversity. Now, what to do next? We want to prevent, actually. And I'll tell you a little bit about how we're starting the efforts to prevent mental illness here in Nova Scotia. We call it preemptive early intervention. There's a history to the term. There was a conference on Prince Edward Island, and the editor of British Journal of Psychiatry was there, and he wrote an editorial about our work when we were just starting. And he said, I heard about PEI on PEI, and so he branded it as preemptive early interventions. We're using it. Peter Tyra. What can actually prevent mental illness? I think it depends a little bit on age. We may think of psychological interventions focused on the parent, perhaps especially with the very young children. We can think psychological interventions focused on the youth, especially with older children and adolescents. We can think of pharmacological or nutraceuticals people use now, nutrition that may have pharmacological properties. But essentially we choose something. We definitely choose something that's eminently safe, because we want to go to kids essentially early on, non-diagnosed, non-treatment seeking population. So when we try any of these, we're facing what I call acceptability challenge, because these kids are not seeking help. We know we can predict who is at risk before they come to seek help, but offering them intervention in a targeted way means, a cold call. We would like to offer your daughter an intervention to reduce the risk of severe mental illness. Would you be interested? It's a strange call to get, right? And our colleagues in Netherlands actually tried something similar. They published this in 2012. I think they started about 2010 before that, trying to do an intervention for offspring of parents with depression and anxiety. And they tried hard. They screened about 11,000 families, found 1,300 of them eligible, and ended up recruiting 26 into their trial. So that's about 2% of the eligible participants. So they failed the acceptability challenge, right? They couldn't recruit. They stopped the trial for failure to recruit. Huge shame. They ended up writing a paper for why this may be so. And they talked about the parents actually probably preferring intervention for them rather than for the kid, and seeing stigma in some of the language around it, the way they were offering it to them. But I think part of the reason is also they're following the traditional medical clinical trial design. So they really made the cold call in the words like I did, and worse, because they were actually saying, would you be interested in a trial where you have 50% chance to actually get an intervention that we think is helpful, or 50% chance of being a control group? That's a kind of complex and strange thing to agree to. So anyway. We try a slightly different approach. So we start with the cohort. The families know us already. And because they already consented to be in the cohort, and part of that consent is the information we give you can be used to evaluate intervention, we actually only need to call those that we are actually offering the intervention to. So, and we also use very non-clinical, non-stigmatizing language. So our approach is from someone they have met before. It's from study coordinator they have met when participating in the cohort. And it is, we would like to offer your daughter, your son, a course of sessions to strengthen their mental health skills. So we're talking about skills training. We're not talking about therapy or intervention. We're not talking about risk when we're approaching the families. And it is nested in the cohort, so they already know most of the procedures other than the actual course. And the course that we're doing now, we call it SWELL, or Skills for Wellness. And this is individualized coaching course for youth aged 9 to 19 years. It's one-on-one. The coach is a clinical psychologist, actually, and it's based on cognitive behavioral therapy, but we don't call it therapy. And there are some core skills that we teach everyone, like problem solving. Break problem into small pieces so that they are manageable, so that you set yourself for success rather than for failing. But that helps nearly everyone. That I think should be taught in schools, but it isn't. And then there are antecedent-specific modules. So if someone comes with anxiety, we do the anxiety modules with them. And if someone comes with unusual experiences, we do the psychotic module with them. And these things are empowering because these kids, they have milder problems that would not be clinical. IWK would not take them at that stage, but yet they see them as big problems often. And the smaller the problem is, even if the kids see it as big, the easier it is to solve. So be giving these kids success experience plus skills to go further. So this is a typical conceptualization. Like the right side of it, the red circle, is what we typically use in cognitive behavioral therapy. That's what maintains a problem and how we can solve it. But we push it into the kind of more virtuous cycle that's in the green red, and that's how would you ideally want to do it, how you want to build strength. So we always go a bit further beyond solving the current problems to really give kids skills to deal with what is ahead of them, to be able to deal with what will come. And we track the progress with something we call YETI, Youth Experience Tracker Instrument. And it seems to be working. We identified 38, this is only a year into it, right? We identified 38 eligible participants within SWELL, and they are randomly selected 18 of them to be offered the intervention, and of the 18 we offered it 15, not just accepted, but completed it. So we have 83% success rate compared to the 2% success rate in the Dutch study. And this may be something about Nova Scotia, but it may be also something about how we can do interventions with youth so that they are acceptable to the youth and acceptable to families. So it got a good start. We're getting good feedback, a lot from the parents. Like, this is a typical one. I wish I could have received such help when I was his age. Once they are in, they will like it. We're getting a lot of good feedback from the kids. Like, my favorite one is a 17-year-old girl who was applying to universities. She was decided she will go to the local university because that's where she knows a lot of people, so it's less frightening for her. But she had social phobia that we cured as part of the intervention, and she will now accept a fellowship in the best university where she was accepted to. So like that's an example where you can change trajectory at a crucial stage. There's another family where a boy feared crossing the bridges, so they were commuting across the harbor here between Dartmouth and Halifax, and each day they spent an extra hour of driving around. So, solving that took us 2 sessions, and it saves the family an hour every day. And so, that you make changes. And the boy who was only 10 at that time, he was so intensely proud of achieving this, because we're doing this. Intervention, and it just got funded through Nova Scotia Health Research Foundation, and it's going through ethics now, so we hope to be starting in spring. And we're monitoring kind of for other opportunities. We're thinking about genetic counseling to prevent cannabis-related brain damage, because that's actually a genetic polymorphism that increases the risk of cannabis-induced psychosis 8-fold.
We think that about 1/3 of kids who are at this much increased risk, that they may want to know. And that since you're not exposed to cannabis passively, you're exposed to it when you're already pretty intelligent and can make your decisions. We think that knowing actually can make a difference. So these are the other things that we're thinking of. Some of them, like generally counseling, pretty innovative, and this will be happening in Nova Scotia over the next few years. It's happening thanks to the work of many people. So I list here not even all of them. There's probably been 100 people involved in this and related efforts over the past 5 years, and it's thanks to funds from Canada Researchers Program, so that they fund me essentially. The Canadian Institutes of Health Research, the federal funding that provides about half the funding for FOBO, and our local agencies, the Nova Scotia Health Research Foundation and Dalhousie Medical Research Foundation, who are doing great work in supporting research locally, and the Dalhousie University Special Department of Psychiatry as well. So thanks a lot for listening. I know this is not exactly your area, but some of you find some of it useful. There is a question that I will repeat.
Yes. Okay, good. Thank you. By the way, that's fascinating. Very
Thank you.
fascinating. We were talking about risks of different environmental impacts that can increase the risk. I'm curious of what you think about the virtual headsets and how they might impact the development process if little children are allowed to use them.
So the question is whether virtual reality can help prevent or cure.
No, might impact the
Oh, can it be a
developmental
risk?
process.
Can
Right.
increase the risk. Okay. I don't know. That's not something we looked into. So the virtual reality gaming has not really taken off in numbers yet. We expect that it will become more available, and of course you can imagine that some of the exposures we may be getting through the web already, I mentioned cyberbullying, may become even more powerful with this. What I know about this is attempts to apply virtual reality in treatment and in therapy, because often what we do to treat anxiety is gradual exposure to something that we fear, but in small doses. And some of the exposures are not that easy to do. Like if you're afraid of flying, it's a high cost therapy if you're going on airplanes 3 times per week. And if you're traumatized in a war zone, it's not somewhere we will want to go with you as therapists. So for some of these exposures, they are being applied with virtual reality. But of course, it has exactly the same potential for causing harm if it's used in the wrong way. But I don't know more specifics. Thanks for the question. Please.
So in your slide that showed anxiety in childhood and psychosis can go on to develop diabetes or higher incidence of diabetes and dementia. If these people were treated at a young age, would that prevent?
Okay.
Or would they just be?
That's an excellent question. So the question is about, we know anxiety predicts mood and psychosis, and mood and psychosis predicts diabetes. So what will curing anxiety prevent diabetes? And this is an open question. We really don't know at this point. It's possible that it will, and it's possible that it will not, because this may be something we call pleiotropy, like the same cause of multiple effects, or it may be a causal chain. It may be that anxiety makes us do something, well, especially it makes us do less of some things. People who are anxious probably move less. And so this is one of the things that we set out to find out, but we really don't know at this stage. It's a really good question. Don't know if we need to stop or if we are free to take another one. It was the same question. It was a really good question, so I'm not surprised more people thought of it. Yes. Yeah.
People's mental health was well managed. Would it change those
Yeah.
predictors?
So I think it will,
To an extent, to what extent it depends. Like some of the links look plausibly causal. Like, for example, it seems pretty likely that, anxiety makes us avoid, not do things. As a result, we lose out, and as a result, we get depressed. That seems to be, a causal chain where treating the anxiety can prevent the depression. Now, when we cross into the physical health, it's more, it's longer time period involved. But there are suggestions like that the effects are cumulative. So if you just get one episode of depression, your risk of diabetes is not as high as if you've been depressed for most of your life. And that suggests that's probably modifying depression may have an effect on diabetes. Same with bipolar disorder and dementia. So bipolar disorder on average predicts substantially increased risk of Alzheimer's dementia. The most effective treatment for bipolar disorder on average is probably lithium. It's in whole population data, we've seen indication that people who have bipolar disorder and take lithium probably do not have increased risk of dementia. But that's very early indicators that changing one can change the other. Please.
I wonder if to go a step further or backwards, what if it's a metabolic disorder in even earlier that could that potentially be the step one that starts the next
this is an excellent question, right? We typically notice diabetes in midlife, right? But the metabolic disturbance may start very early. So it may actually be the primary mover that manifests first as mood and later as diabetes. And this is something we intensely looking into, and some other people in Canada, like Gerald in Saskatchewan, is really looking into the molecular background behind this. We here in Halifax, Dr. Cindy Colkin and colleagues have demonstrated that impaired glucose tolerance, so not diabetes yet, but pre-diabetes, actually leads to worse response to treatment in mood disorders, in bipolar disorder. And she's trying to use an anti-diabetic medication, these pre-diabetics, to see if it will improve the course of bipolar disorder. So yes, the fact that diabetes manifests later in life does not mean that it's not earlier in the causal chain. Another excellent point, thank you. Can we still, or are we on time? No. So please.
I maybe I'm asking the obvious question, but if your sessions with these young children, teaching them how to cope with life, if that has such an impact on they and their families, like why isn't it more global? Why aren't we teaching?
Okay, so the question is about accessibility or availability. Obviously, I talked very nicely about this intervention, so it looks like it might be helpful. And so why are we not giving it to all kids? And this is a good question. So what we're doing are fairly intensive psychological interventions, and they are similar to the interventions that we would typically use to kids who are, or adults who are actually fully diagnosed with a problem, right? So interventions like that are available, and in my experience they are not as available as they should be. That's for sure. And it's I worked previously in the UK, and the availability of these interventions is better in the UK than it is in Canada. I dare to say that actually the quality of this intervention is better in the UK than in Canada. We ended up recruiting our research therapists from the UK because we couldn't find in Canada someone who can do it to the standard. And we tried 3 times. It's something about the health system, how it is funded, how it is organized. So here it depends more on private practice and interests of health professionals. In the UK, it's a national health system that's more centrally directed, and it's a service. think National Health Service, it really says something about it. So, but yet even in the UK, with more investment into this, more direction, more program training, they're still not catching up with the demand. So it's very difficult to provide enough good quality psychological treatment. And that's why many people think, well, can we do something on the internet or a smartphone app that will kind of replace that, right? And the short story is none of these can replace that at the moment. But the provision and availability of this is a huge question. I'm kind of interested in more, basic question, whether this can actually prevent severe mental illness, and I think demonstrating this, because it's quite a high aim, I think if we're able to demonstrate this, it may just add an argument towards making these interventions more available. But another excellent question. Thank you.
I'm not exactly sure how to ask this question, and I'm not a medical person, but I wonder why there's so much emphasis on mental health and the diagnosis of mental illness. We don't diagnose cancer illness. We group. But in fact, a lot of mental illness seems to have a physiological basis, and so I wonder sometimes why. Do you foresee a time?
The question are debated in disorders like cancer, and is that the core of?
It's like that stigma. We always call it mental illness, but we don't call other illness something that gets grouped so.
Okay. So why we use the term mental illness as opposed to physical illness, right? Okay, yeah, that makes more sense. I do, on one hand, yes, it would make sense to use specific diagnoses. On the other hand, the boundaries between types of mental illness are actually less clear than the boundaries between different types of cancer. I think it comes down to the fact that we tend not to have a distinct and objective diagnostic markers for specific mental disorders diagnoses. So although we have many associated physiological measures, none of them is good enough to diagnose, or brain measures, and none of them is specific enough to one particular diagnosis. So I think it does reflect the lesser state of knowledge. That's why I like to do psychiatry. We know less about mental illness than we know about cancer or about cardiovascular illness, and that makes it more exciting on the research side. But yeah, we are behind. The brain is more complex.
Thank you very much.
Thank you for great questions.